welcome. You're all dropping in, and we're really excited to see you. Um, if you can, please drop in the chat who you are, where you're from, and do you have a question that you need answered today about this whole Advocacy Day thing that PNHP is going to be engaged in? We are going to spend some time going through lots of different things, hopefully anticipating all your questions and answering all of them. But we are intentionally leaving lots of time at the end of this in order to take those questions. So please let us know who you are, where you're from, and if you got questions, tell us what question you need answered. We'll give folks another minute or so to trickle in. But for those of you that don't know, my name's Phil Verhoef, and I'm an ICU physician in Hawaii. I'm also the immediate past president of PNHP, and I really couldn't be more excited about this upcoming Advocacy Day. I think it's going to be an absolute blast. A few things to say about it as we get going. Again, please do use the chat if questions do come up. We will be monitoring the chat, and we will either try and answer them in real time, or we'll save them and get to them for later after the presentations are done. But what you're going to get today is a really nice overview, an introduction to advocacy in general, to policy making. So we're going to cover all of that. So, this is honestly PNHP's first real lobbying day. So we've never done this before. We have, lots of people that have done this kind of advocacy before, but PNHP as an organization has never descended upon Washington, D.C., partnering with SNAP to get in front of lots of legislators and their staffs. And so this represents a real evolution for us, a real, development for us in our advocacy and our activism. And I think it's absolutely amazing. I think many of you have probably had the chance to meet or talk with your legislative staff before, either at home in your districts or maybe in other opportunities. But this is the first time where we're saying you can actually go to them and talk about single payer. Me personally, I've met my legislators many times. I've done it working with the American College of Physicians, the American Academy of Pediatrics, the American Thoracic Society, the American Association of Immunologists. I've done it just on my own. But now we're actually going and we're prepared to talk to them about single payer and about a lot of the other work that they're doing, which I think is really exciting. I think another thing that's super exciting is that we've got people from students all the way up to retirees across the spectrum. And so, we're going to be bringing together lots of different kinds of people that are going to be joining us in DC in just about a week and a half. I don't know what to expect about this whole government shutdown thing being going on, but we will still plan the rally whether or not the government is reopened, and we will do our best to actually continue to have those meetings. Those are happening regardless of the shutdown. Obviously, it would be more effective if we had the opportunity for meeting everyone, but we will see. Time will tell, right? So let me go through an outline of what we're going to cover in the next hour or hour and a half or so. And so, Dixon, if you jump to the next slide for me. Basically, we're going to cover a little bit about policymaking and lobbying in general, and we're going to talk about what some of our asks are. We're going to talk about the WISER model, which is the the prior authorization into traditional Medicare. We're going to talk about our recently released equity report, and then you're going to have the opportunity to think about other things that you might want to ask your legislators about. We're also going to talk about what to expect in a lobby visit. If you've never done a lobbying visit with a legislator on Capitol Hill, we're going to provide you a basic structure for what you can expect from that. Obviously, we'll go into more detail on this stuff during the annual meeting itself, but this will give you a preview of that so that honestly, we don't have to cover all that stuff when y'all are here in DC, and we can actually hit the ground running. We'll give you a sense of what to expect on that Advocacy Day, which is Monday, November the 3rd, I believe. And again, for questions and answers, we're please put them in the chat. I want to kind of move the presentations along without a lot of interruptions there. But if we can answer them in the chat, we will. Otherwise, we're holding about hopefully 25 to 30 minutes of time after the presentations are done, when we'll be able to get to those. And so with that, I would like to introduce our first speaker. That's Kyle Patel. Kyle is a third-year medical student at Johns Hopkins, and he's interested in primary care. He is going to give us a little rundown about Congress and lobbying and what all this is about. So, Kyle, the floor is yours.
All right, thank you so much. And hello, everyone. Glad to have you all here. So what is policymaking and how does it actually work? Next slide, please. All right, so there's a lot of avenues to policymaking that we may not always think of, right? We think of legislation, bills that are getting passed in Congress, but there's a lot of other ways that policymaking occurs. And policymaking at large are rules and ways in which we have to live our lives based on how those rules have been implemented or passed or interpreted, right? So the executive branch also has a big role to play in the implementation of laws that are passed. The courts interpret those things. Regulation of these laws all determine how those laws are actually interpreted and applied. Funding determines, whether laws actually have power and other actions. And then advocacy and lobbying obviously influences what kinds of things in all of these things that I've mentioned can happen and how they happen. And also at the bottom of each slide, you'll see a lobbying connection, which is, I'm going to go through all of these different avenues that I've talked about, and that kind of just relates an example in which where you can see how something like that happens. All right, so legislation, the first way, the one that we're probably all very familiar with, we have the House and the Senate at the federal level, at least. These are the two chambers of Congress. Different types of bills originate in each one, and those have to be passed separately in each chamber, and then the other, and then they have to be reconciled, and the same thing has to be eventually sent to the president. So there is a long process in doing that. Amendments can be added during any of this process. Resolutions are more so kind of statements of support or non-support that members of Congress will pass, stating something, maybe celebrating a certain day, or saying that we support Medicare for all, but they don't have the weight of law behind them. And then the process, as I mentioned, all of that stuff happening together. So one way that you would be involved in this through lobbying potentially is emailing your Congress member, asking them to co-sponsor the Medicare for All Act, which is a piece of legislation that is in Congress right now. Okay, and then we get to the executive implementation, right? So once laws are passed by those chambers and they go to the president has to sign them for them to actually be implemented. There's also executive orders, which can be issued, those are interpretations or rules that have authority as well on how things should be done. And then you have federal agencies, which are under the purview of the executive branch, things like Department of Health and Human Services, the CDC. Those are all under federal agencies, and those apply a lot of the laws that have been passed with funding. They determine research, things like that. I'll talk a little bit more about it later, but they're very important in the application of laws. And then we have the budget, obviously, which the president issues a budget recommendation essentially at the beginning of the appropriations period. And then those kind of recommendations are taken by Congress and modified to get to the actual funding for that year. Then we have the courts, right? So the courts do a lot of different things. They determine constitutionality, whether or not laws can actually stand. We've seen a lot of that, obviously, especially recently. Statutory interpretation, when a law is passed, if there's a question about how it should be applied, that can be, it's sent to the courts and then they will determine how it's applied. So that obviously influences policy. Checking executive authority, theoretically, they're supposed to do that as well. If there are things that the executive branch does that it's not supposed to. And then setting standards of care. An interesting kind of example of this is with Roe v. Wade to determine what legally viability was, and that obviously directly influences medical care. So there's a big part of the courts and actually, how these laws are eventually interpreted and applied. And there's a lot of ways that physicians and healthcare workers do this in terms of lobbying on this side. An example is submitting amicus briefs um, to cases. We've seen that in Roe v. Wade, and then also just generally, you could do this in the future for something. Amicus briefs are kind of they're called friends of the court, and they're statements based on expertise, recommendations that you can give for a case, and it can have significant influence. Then we have regulation. This goes with the executive agencies, as I was saying. So CMS is under Health and Human Services, Center for Medicare and Medicaid, and they make rules based on how laws have been passed and how those are actually going to manifest in terms of Medicare and Medicaid spending limitations, things like that. You have CMMI, which we'll hear about a little later, Center for Medicaid and Medicare Innovation. And then they also provide guidance, do grant making and distribution, like the NIH, for example. That obviously determines what is funded and what is researched. And then data collection, like with the CDC, they based on the data that they collect, that influences not only policy, but then also how policy is applied later on. And they have formal periods when they're making these kinds of rules, at least CMS does. So a great lobbying connection for this, at least, is submitting a formal comment during those public periods, which can be pretty influential as well. Funding, this is probably the most complex, and I honestly don't understand a lot of it still, but you have the president's annual budget, as I mentioned, which is kind of a guidance. Then there's annual appropriations bills. Congress has different committees that, different areas, defense, agriculture, education, they determine what their budget is going to be for the year. That has to be passed in the process that I mentioned. Then you have discretionary versus mandatory spending. Mandatory spending is things that have to be spent every year, like funding for Medicare, versus discretionary. It's things that are at the discretion of Congress, essentially. And that's important when we talk about things like the shutdown, because mandatory spending has to be spent. And so it's going to be spent no matter what. But discretionary funding is usually what is put on hold. And that's where continuing resolutions come into play, which are things that have to be passed in order to, if there isn't full funding for certain programs throughout the year, which is kind of what they're trying to negotiate right now. Supplemental appropriations are passed if there's some event that's unexpected. For example, COVID, we saw that, they passed a big bill to allocate funding for that. And then you have multi-year budget authorizations in which they will say that like things will be funded for a certain amount of time. Like the infrastructure bill did this, for example, for 5 to 10 years. It was supposed to outlay funding, but that funding has to be passed every year. So there's a lot of different ways that funding is regulated and kind of made. And, it's important, obviously, for what can be supported in terms of the bills and laws. And we'll hear a little bit more about that later. And it directly ties into some of the advocacy that we're going to be doing. And yeah, I have an example there as well about funding for studying single payer models. And then this is kind of the most important part, right? Advocacy and lobbying. This is where we come into play. And these are different avenues kind of conceptually, right? Direct is more like when you're talking to a legislator or someone in the government through visits, which we'll be doing, testifying at meetings or hearings, calling them. Indirect is more in the community, raising awareness, organizing within spaces, right? And then you have kind of a separate thing from like grassroots lobbying, which is lobbyists, industry, donations. But the big part of this is building power, right? How do we legitimize ourselves as an organization, people who these congressional members should listen to, and we already have a lot of that weight innately, depending on based on who we are and the types of people we are. But we also have been very continuous with this kind of advocacy, repeated visits to offices and contact with offices is a great way to do that, which many of our members have already been doing. A lot of PNHP and SNAP members also collected petitions with that they're going to be bringing to Advocacy Day. And so all of this kind of goes into building power and our organization having that authority such that when we go and speak to these congressional people, they're going to listen to us and want to listen to us. And I think we've done a great job of that, and we're going to continue doing that this weekend. And that's all. And I think Belinda's next.
Excellent. Hi, everybody. Just a second, I get my slide up here.
For you guys, Belinda is a doc in the Atlanta area, I believe a psychiatrist and a member of our board also has put a ton of work into this equity report. And thank you, Kyle. That was really a fantastic overview of just what we're embarking on.
Thank you, Kyle, and thank you, Phil. Okay, so I'm going to launch right into a briefing for all of our advocates on this call. Good evening, everybody. Welcome. This pre-conference Advocacy Day webinar is so exciting for me because I see there are 88 participants on this call, and so I know we're going to have a lot of advocates in DC. And so over the next about 15 minutes, I'll present some findings from our brand new hot off the press equity report. And the point of this is to help guide your advocacy with members of Congress and their staff, and also to just inspire you as we head into our annual meeting and our Advocacy Day. So many of you on this call, I'm assuming, will be present at the annual meeting, and you'll hear even more from the equity report at the meeting. But tonight's talk is really meant to present the highlights and some of the data that led us to conclude unequivocally that Medicare Advantage perpetuates and often exacerbates the existing inequities in our healthcare system. And this message is extremely important for our legislators to hear because it is the very opposite of the message that members of Congress are hearing from the insurance industry. So let's get started. So PNHP's equity report, just released in October, was developed in partnership with researchers at Johns Hopkins and received funding support from Arnold Ventures. The report is really a rigorous analysis to assess Medicare Advantage insurers' claims that their plans promote equity. And for this report, researchers analyzed nearly 2,500 Medicare Advantage plans. And here's what we found. Medicare Advantage perpetuates and often exacerbates racial inequity. We found that 25% of Medicare Advantage plans have higher levels of Black, Hispanic, or Asian enrollees than the local demographics would predict. And we found that people of color are disproportionately enrolled in plans with lower star ratings. And there will be more on star ratings in a bit. These lower quality plans are characterized by the kind of tactics we see from for-profit health insurance companies, the higher out-of-pocket costs, more prior authorization denials, narrower networks, and worse clinical outcomes for patients. And there is so much robust data in this report that I'm not going to try to present that to you tonight. I'm really excited to be able to present some of that in more depth at the annual meeting, but I'm going to give you guys on this call a very quick preview. We found that although Black enrollees are choosing Medicare Advantage plans with lower premiums more frequently, they end up with much higher financial exposure with very high out-of-pocket maximum compared to other plans. We are finding that the supplemental benefits that the Medicare Advantage plans have promised are not what they're cracked up to be, and that people from minority groups who are enrolled in Medicare Advantage get less healthcare than white enrollees across various types of healthcare. We also found that Black people in Medicare Advantage plans have more problems accessing care due to cost, and that becomes even harder if they're in poor health. And we found that Black Medicare Advantage enrollees are more likely to have complications and be rehospitalized after surgery. And here's a really big finding. This is a very large study that found that Medicare Advantage plans are more likely to deny claims when the claimants are Black. So suffice it to say, Medicare Advantage is not a solution to inequity. Now let's take a deeper dive into the equity report so we can prepare you for your legislative visits. So a key concept to bear in mind here when pushing back on the insurance company claims that Medicare Advantage is a solution to inequity is to remember that diversity is not the same as equity. So although people of color are more likely than white people to enroll in Medicare Advantage plans, they're disproportionately concentrated in the lower quality Medicare Advantage plans. And people of color also fare worse on most measures of health. And so the take-home message here is that Medicare Advantage companies' practices that prioritize profits over people perpetuates inequity. I just realized there's like 8 P's in that sentence. Highlights from the equity report also include this concept of the gap trap. Now, allow me to explain what we mean by the gap trap. You'll find this in the report if you've already seen it. So this has to do with traditional Medicare. So traditional Medicare has no upper limit on out-of-pocket costs. So as you might imagine, it can be quite expensive to pay the co-insurance and high cost if you're hospitalized if you have Medicare, traditional Medicare without a Medigap plan. So most people in traditional Medicare actually also purchase a Medigap plan in order to limit their expenses. But Medigap premiums are unaffordable for many. It can cost us about $2,000 per year. So our report shows that Black people and people from other minority groups are effectively steered towards Medicare Advantage, not by their choice, but because of financial constraints that leave them with no real choice. They can't afford the supplemental insurance through Medigap, and so they're relegated to enrolling in these Medicare Advantage plans. A third highlight from the equity report is that, and this is really important that we want to share with members of Congress, is that the evidence that insurance companies are presenting to them to support their claims about the advantages of Medicare Advantage plans are based on flawed research. Now, most members of Congress already know that Medicare Advantage has widespread upcoding that drives up their capitation rates and leads to billions of dollars in overpayments. But few realize that the upcoding also confounds virtually all of the industry research. So the research is not adjusting for upcoding. And so it ends up comparing healthier upcoded Medicare Advantage patients with the genuinely sicker, accurately coded patients in traditional Medicare. And that just creates a meaningless analysis in which the upcoded, healthier Medicare Advantage enrollees will have better outcomes. And so the insurance industry is using flawed data when they're presenting evidence that's trying to push members of Congress to support Medicare Advantage. And now, before we go further, there are some important concepts I just want to define. So when we talk about lower quality plans, what are we really talking about? We're talking about the star quality ratings. So the star rating system is something that CMS developed and uses to determine whether plans are meeting certain criteria, certain metrics on quality of care and service. So the star ratings are pretty crude and imperfect, but they have significance for patients and for insurance plans. So for patients, a star rating of 5 or 3 or 4 tells them something about the quality of care they're going to receive across various things like cancer screening, care for diabetes. And also the star ratings measure their service experience. So how likely are enrollees to leave their plans? How timely are prior authorizations executed or appeals completed? And the star rating system has very big implications for the insurance plans as well. So insurance plans that have Medicare Advantage plans that have a higher star rating will receive higher payments from CMS. So CMS increases the base payments to Medicare Advantage plans that score at least 4.0 stars. Remember the 4 stars, that's actually a really important number for this. And CMS also pays an additional quality bonus to some of those plans, and those plan bonuses result in increased payments to the Medicare Advantage plan, which can then be used to fund increased or enhanced benefits for enrollees in those plans. So those plans can be able to offer additional supplemental benefits, lower copays, and maybe even lower premiums. The trouble with this model is that people of color are concentrated in the lower quality Medicare Advantage plans. So when you look at this graph, I haven't thrown the data up here yet, but if you see the x-axis, it doesn't start at 0. And we did that on purpose here on this slide because the focus is where the 4 is. Because at the 4, that's the star threshold for quality bonuses. Less than 4 stars, you don't receive the quality bonuses. More than 4 stars, you receive the quality bonus for those plans receive the quality bonuses. So when you look at how this breaks down across race, on average, the star quality rating is 4.3 for plans that are where there's a higher concentration of white enrollees. Now, if you look at plans with a higher concentration of Black, Hispanic, and Asian enrollees, this is what you find. They're all on the other side of that 4-star threshold for quality bonuses. And, so you might look at this data and ask, well, why are minority enrollees choosing these lower quality plans? And the answer to that is actually a central finding of our analysis. It's not that people of color are bad shoppers. In fact, there's evidence that when you're offered a 5-star plan, Black enrollees are actually more likely to choose a high quality plan than even white enrollees. The reality is that people of color are less likely to live in communities that even offer the higher quality Medicare Advantage plans. So now on top of the star rating quality bonuses, the CMS quality bonus structure provides another mechanism whereby Medicare Advantage companies can effectively leave people of color behind. So CMS gives a double bonus for quality in geographic areas where there is below average traditional Medicare spending. And areas with below average traditional Medicare spending is just another way of saying healthier communities. So that additional bonus, this double bonus, it drives more CMS money into healthier, wealthier, wider communities. Again, effectively relegating communities of color to these lower quality plan options. Okay, so right now I'm going to recap the concept of the gap trap so that I can show you how the gap trap interacts with the Medicare Advantage plan financial incentives to further drive inequity. So just to recap, the price of Medigap makes traditional Medicare unaffordable for a lot of people of color. And Medicare Advantage insurers are aware that this traps people of color in Medicare Advantage plans. They don't have the option for traditional Medicare in those areas. And since they know they don't have to compete against traditional Medicare for people of color's businesses, it's really a trap. And this enables the Medicare Advantage plans then to get away with administering low quality plans, and it facilitates the practices that they use to prioritize profits over people. So they can get away with narrow networks, prior authorizations, restrictions, and lots of delays and denials simply because they don't have to compete with traditional Medicare in those communities. And so there is no business incentive for them to improve upon their lower quality plans. And that leaves people, and this is almost like a gap trap, if you will. That might be weird, but it made sense to me. I'm going to move on. Anyway, so I did show you this slide a moment ago, and I'm showing it to you again because it is just a very dramatic representation of how Medicare Advantage plans perpetuate, and in this case, exacerbate inequity. And this is data that was published earlier this year in Health Affairs Journal and shows that Black people and other and Hispanic people are more likely to have their initial claim denied by a Medicare Advantage plan. And so, and just to be clear, this doesn't mean that there's some nefarious, racist medical director sitting in an office somewhere and stamping denial on claims because they noticed the claimant is Black. What this is really a consequence of is people of color. This is more systemic. People of color are being enrolled in these lower quality plans where they are more likely to encounter things like denials, prior authorizations, and all these other profit over people tactics that insurance companies use. And again, people of color aren't choosing this. There simply aren't enough choices based on cost constraints. And so there are significant business imperatives that are driving Medicare Advantage plans to continue to trap people of color in these lower quality plans. So, I've shown you how, people who can't afford the cost of supplemental coverage through a Medigap plan, end up with no choice. They opt for a Medicare Advantage plan. And, because the plans in their community aren't competing against traditional Medicare, they can get away with offering these more restrictive plans. And then on top of that, this double bonus system allows insurance companies to get double quality bonuses in certain situations, only if their plan is operating in counties with below average traditional Medicare spending. Again, a proxy for healthier patients, which in our healthcare system, unfortunately means healthier patients more likely to be in white communities. So there's further disinvestment in communities of color and continues to encourage more restrictive Medicare Advantage plan designs because there's really no consequences for that. So in summary, is Medicare Advantage a solution to racial health disparities? Absolutely not. What Medicare Advantage is really doing is that it is trapping people in these plans with low premiums. The supplemental benefits they advertise are really quite modest in the end. And ultimately, what happens to the people in the plans is their choices of physicians are limited. They are barriers to care, and this weakens their financial security with their high out-of-pocket costs. So just to reiterate, this is our message to our elected officials. Medicare Advantage is perpetuating racial inequities and in many ways making them worse. And so what we want to do with this equity report is to return to Medicare's original promise of equitable access to care. And then the report lays out how we can do this. One way is by arming us with the truth, the facts we need to expose the truth about equity. Medicare Advantage perpetuates and worsens disparities. Say it with me. We are going to say this multiple times on Advocacy Day. And also that industry research is confounded by upcoding in Medicare Advantage so that elected leaders can push back on what they're hearing from the insurance companies. And what we also want to do is let our Congress people know, our legislators know, that in order to ensure that Medicare Advantage plans are actually equitable, Congress would need to act to eliminate all this geographic variation in plan offerings and ensure access to high quality plans in all communities. We would also need to call on Congress to end this gap trap by introducing low out-of-pocket maximum in traditional Medicare. And we want traditional Medicare to include supplemental benefits like dental and hearing, so traditional Medicare can match the actuarial benefits in Medicare that are present in Medicare Advantage. Now, let's be clear. We are Physicians for a National Health Program, and we want $0 out-of-pocket maximum in traditional Medicare. And what we really want is single-payer universal health care for all. And right now, we also have to be fighting back aggressively against this Medicare Advantage takeover. We know that we can fund equitable solutions because there are billions of dollars in Medicare Advantage overpayments that can be redeployed. And so what do we want from legislators? We want them to be aware of the information contained in this report, and we want them to know not to fall for the insurance industry claims. And so here are our goals for our legislative visits. You're going to have focus training on November 2nd, and then on November 3rd, you're going to meet with members of Congress and their staff. We're going to tell them who PNHP is and what we care about, and that's our patients. We're going to push back on the insurance industry's false claims that Medicare Advantage improves equity and help members of Congress to better understand the harms of Medicare Advantage. We will highlight the major finding from the equity report: Medicare Advantage perpetuates racial inequity in healthcare, and we're going to expose how upcoding corrupts the foundations of most of the false claims that Medicare Advantage companies make about better outcomes. And we're going to introduce solutions to address inequity in Medicare Advantage and protect traditional Medicare. So there's really a simple ask for our legislative staff meetings. Once we've presented the information, we will ask the staffers to relay all of this to their members of Congress, and then we will ask if we can meet with the member of Congress after that to help determine which parts of our proposals they'd like to move ahead with. And I will stop there and turn it over to Daniel.
Awesome. Thanks, Belinda. And as Daniel's getting set up, just to introduce you to him, he's a fourth-year medical student at Cornell. He's going to be going into emergency medicine. Belinda, that was amazing. And obviously, we're going to have so much more information to share about that. Now we're going to dive into one of our other asks, which is going to be this thing called the WISER model. And so, Daniel, tell us why WISER is not wiser.
All right. Thanks, Phil, and thanks, Belinda. I'm talking about a new dangerous government initiative called the WISER model. It's quickly becoming a primary lobbying objective for PNHP because it aims to privatize Medicare Advantage. And we can go on to the next slide. So the WISER model stands for the Wasteful and Inappropriate Services Model. The groups involved in the WISER model are the Centers for Medicare and Medicaid Services, which I'll refer to as CMS, and the Centers for Medicare and Medicaid Innovation, which I'll refer to as CMMI. And CMMI, it's a smaller group within CMS, and their responsibility is to innovate payment models to save the government money. CMMI created WISER, and now CMS is rolling it out. So what is the WISER model? It's a pilot program that's implementing prior authorizations into traditional Medicare. It's slated to start on January 1st, 2026, and it's supposed to last for 6 years. And right now it's going to be initially rolled out in 6 states: Arizona, New Jersey, Oklahoma, Ohio, Texas, and Washington. So why is CMS using the WISER model? Well, they say it's to reduce unnecessary medical spending in traditional Medicare. In other words, they're saying that they want to cut down on waste, fraud, and abuse within traditional Medicare. They propose to do this by implementing more prior authorizations into the program, and they intend to process these claims more efficiently with enhanced technologies like AI. So in other words, they want to pay companies to use AI to then deny traditional Medicare enrollees their medical care. And the truth is that they want to privatize all of Medicare, and the best way for them to do that in their head is to make traditional Medicare more like Medicare Advantage. So we just want to go through some of the major problems with the WISER model. And the first one is that it proposes to work with the same private contractors that Medicare Advantage companies use to process their prior authorizations. And furthermore, these corporations will receive a percentage of the savings they deliver, which incentivizes them to deny more claims so they can keep more of the money. The second big problem is that they will be using AI and enhanced technology to process claims faster. We know from a lot of research that when Medicare Advantage began using AI to process claims, patients experienced far more denials of medical care. Third involves how the WISER model can choose which services to target. So when this program starts in 2026, they say they're starting with services that are vulnerable to fraud, waste, and abuse. And that's going to start with a list of procedures and treatments that includes things like cervical fusions, epidural steroid injections for pain, and deep brain stimulation for Parkinson's disease. Now, targeting this initial list with prior authorizations, it's bad on its own. But what's more alarming is that the model is free to expand to other types of care that are subject to prior authorizations, and they can do this really at any time without congressional approval. And then the final huge problem with the WISER model is that if they are able to show CMS that they're saving money using the WISER model, then they have freedom to expand to other states without congressional approval. And I'm sure some of you might be wondering, did these 6 initial states even agree to participate in the pilot program? And the answer is no, they did not agree to participate in the first place. CMS just decided on these states. So considering all these problems, PNHP's position is that we oppose the WISER model because we know the damage that prior authorizations cause. We know they create widespread delays in coverage, they harm patients, they cause moral distress in providers. And furthermore, we oppose the privatization of Medicare. So our goal during this advocacy day is to make Congress stop CMS from using the WISER model. And we're going to achieve this goal through 3 asks. And we just want to be upfront that these asks are a bit complicated and that your advocacy day group will need to decide beforehand which asks are applicable to the members of Congress you're speaking with. So you don't need to think about this now, but whether you're speaking with a House member or a Senate versus a senator is important. And then if you're speaking with a Democrat versus a Republican may be important. And they're going to determine which asks you use. So now we can take a look at them. So first, we want all House members, also known as representatives, to co-sponsor Representative Pocan's House Resolution 704. This resolution aims to express congressional disapproval of the WISER model. Currently, it's been co-sponsored by 17 House members, all Democrats. And as Kyle said before, resolutions are not binding, but they're still really strong and worthwhile statements, which is why it's an ask. And we want every Democratic and hopefully also some Republican representatives to co-sponsor this resolution. Now, by the time, oh, sorry, you can go back. By the time that we have our advocacy day, it is possible that a similar resolution will be introduced into the Senate. And if that is the case, then we're going to want all of the senators we meet with to support that amendment or that resolution as well. So yeah, our first ask is that representatives co-sponsor Representative Pocan's resolution. Our second ask targets the budget bill pathway. So as Kyle said, each year the government must pass a budget, and I'll get into the details, but generally we want elected officials to block CMMI from using money to pay for the Wiser model. In September, the House actually did pass an amendment doing just this, and they did it with bipartisan support. So that amendment, also known as Frankel number 5, is now in the House's budget bill. So if we can get the Senate to pass the same amendment, that's going to increase the odds that this amendment makes it to the final budget bill. Regardless, both the House and the Senate are going to need to agree on the final wording of the amendment during a joint conference committee. And if that happens, then both the House and Senate are going to need to vote to pass the bill. So for this ask number 2, our asks are different for senators versus representatives. For senators, we want them to both introduce and then support the same amendment into the Senate budget bill. While for representatives or House members, we're going to ask them to vote to include the same language from this amendment into the final funding bill that eventually comes out of the Joint Conference Committee. Basically, for House members, we just don't want anyone to change or remove the amendment for the final budget bill. So to recap, first, we want representatives to co-sponsor HR 704. Our second ask is that we want members of Congress to block CMMI from funding the Wiser model in the budget bill. Now, our third ask, this is specifically for Republicans, but it may also be applicable to some overly cautious Democrats. Everyone across the country, even Republicans' constituents, hate prior authorizations. So it shouldn't be too surprising that some Republican members of Congress are being pressured to oppose Wiser. Like I said before, some Republicans even voted on the bipartisan House amendment, Frankel number 5, to block Wiser. That being said, Republicans are very afraid to oppose the health insurance lobby. They're afraid to oppose CMS and also Donald Trump. So if you're speaking with a Republican member of Congress or an overly cautious Democrat, you may need to tailor your asks a little bit. Of course, we still would like for them to sign on to HR 704, but they probably won't do that. So if not, we want them to at least privately pressure the head of CMMI, his name is Abe Sutton, to stop the Wiser program through either a private letter or a private phone call. And when you're lobbying, you need to be able to follow up with members of Congress to ensure that they're following through on what you've asked of them. So if you're using ask number 3, we need to ask them to trust us with a confidential phone call later on so we can track progress on this ask and make sure that they're following through on it. So these are our 3 asks. First, for all representatives, co-sponsor HR 704. Second ask is the budget bill pathway. We want to make sure that an amendment is included in the annual budget blocking CMMI from funding the Wiser model. And our third ask for Republicans and overly cautious Democrats is to privately influence CMMI to stop Wiser. You can feel free to talk with any of the organizers when we're in DC for guidance in tailoring your asks, but know that there will be time put aside at the annual meeting to get together with your group and discuss which of these asks makes most sense for your member of Congress. You can move on to the next slide. And some people have asked already, but there will be a 1-pager sent over to you on the Wiser model, and that will be left behind with members of Congress. And in addition to that, there's also going to be a paper sent to you with talking points for you to look over. It's going to give you talking points on how to advocate for our asks and also some responses to some of the more likely questions you may be asked by members of Congress. I won't get into all of them, but I'll leave you with one important one that connects with our Medicare Advantage work. A likely question you may get is, if we choose not to use the WISER model, how are we supposed to control excess costs in Medicare? And your answer could be, if they ask that traditional Medicare is one of the most efficient programs we have, and a more direct way to control waste in Medicare would be to stop overpayments to Medicare Advantage companies and recover the $140 billion of taxpayer funds that goes to them. Thank you very much, and I believe Angela is going next.
Awesome. Great job, Daniel. Angela, you were going to tell us a little bit about the outline of legislative meetings. And just as a reminder, Angela is a med student at Vanderbilt. Take it away.
Thanks, Phil. Thanks, Daniel. Hi, everyone. Just like Phil said, I'll be going over the general outline of a legislative meeting. This is just as a way to do some level setting for us as a group and to set some general expectations for how these meetings are usually run, just so we can all be on the same page for our advocacy day in about a week or so. And then again, like Phil said previously, you will be going into more detail on this on November 2nd at the in-person workshop. So today is just a little preview. So there's technically no single right or wrong way to run lobbying meetings, but in general, most lobbying groups and nonprofits will follow a general organized structure and will assign similar roles. And I'm sure many of y'all have attended these types of meetings already, and you probably followed a similar guideline to the one that we will go over today. And for the purpose of this training webinar, we are actually going to just follow the visit guide that was actually made specifically for our Summit Lobbying Day, just so you can become familiar with it ahead of time. I've screenshotted it here on my slides. Please don't be alarmed by the large amount of text. I know it's a lot. You will receive a draft of this guide again in person. I'm just showing it here so you can have some familiarity with it and then refer back to the slides if needed. So preparation for the meeting, first thing you need to do is assign roles. We assign roles ahead of time so the meeting is run efficiently, things are communicated clearly, there's no awkward pauses trying to figure out whose turn it is to speak, etc. Some people may need to double up on roles, that's totally fine. Also, not everybody attending the meeting needs to have a speaking role. There's still power in just having more numbers overall. And I'm just quickly going to go through the roles that we have laid out in our specific visit guide here. So you can just focus on that first column that's labeled roles. Again, don't worry about the large amount of text. You'll get to go deeper into the details later on. So first role is the leader / facilitator. This person just agrees to quote unquote chair the meeting. They manage time. They make sure the agenda is set and covered. And generally, their role is to encourage as many people on the team as possible to speak and to assure that the member of Congress or their staffer has a chance to respond to the things that we bring up in the meeting. Generally, the leader / facilitator will open and close the meeting and make sure that it follows a general flow. We want to emphasize that the facilitator should not dominate the conversation, but rather be the one that makes sure that everyone else gets the opportunity to speak. We do not want a single person or voice to dominate our meetings. So as a leader, it's sort of facilitating the participation of others. Next is the note taker. It's pretty self-explanatory. They just keep a record of the visit. It's also very important for them to record any questions or requests that are made by the staffer / member of Congress, and to know any responses that us as a visit team make to that staffer, just so that we remember to follow up on it after the meeting is over. Next role is the presenter. Presenter will outline key information on an issue using prepared talking points. This presenter does not have to be necessarily an expert on the topic. They should feel free to let other team members jump in as well when answering questions or providing additional information. Their main goal is to provide general background around a specific issue that you're bringing up, and then at the very end, make a very specific ask to the member of Congress or staffer. And you can also have multiple presenters in a meeting if you have more than one issue or talking point. Next, we have a storyteller. This is somebody who can provide a compelling personal story to show how the decisions made by this member of Congress affect real people. It's essentially appealing to the representative or senator's pathos. And I'm sure many of you know that many of these members of Congress respond better to stories that are more personal, more so than stats. And so a storyteller can be very key to being very compelling during one of these meetings. They typically prepare their statements ahead of time, make sure that it flows well and that it's very relevant to the visit. Again, you can also have multiple storytellers, just like presenters. And then the last role is a photographer. They kind of have a fun job. They're in charge of getting a photo at the end of the visit, and hopefully the staffer or member of Congress consents to that photo. After roles are assigned, sorry, could you go back? I got 2 more bullet points, sorry. So after roles are assigned, this probably goes without saying, you should do some general research to make sure that you're prepped. You can be well-versed in the topics at hand. You can try to answer questions on the spot if needed, but again, don't panic. If you can't answer on the spot, you can always offer to follow up afterwards. And then the final step of preparation, especially if you have a speaking role, is to practice. Next slide, please. Okay, now that roles are assigned, I'll just quickly run through a general outline. And again, showing one of the pages of the visit guide here on the right. So the leader / facilitator will open up the meeting. They can introduce themselves, thank the staffer for their time. And then what they should do is give a brief 1 to 2 sentence introduction of the organization that they are representing. So in this case, it would be PNHP or SNAP. You can use the introduction that is given in the visit guide verbatim. And then typically they can ask how much time the staffer or member of Congress has delegated for this meeting so that the timekeeper knows when to signal to wrap things up and so you don't get unexpectedly cut off. Then the leader can also give an appreciation that should be specific to this member of Congress. This is to establish a sense of common ground and to show that you, as a lobbying group, are invested in and are aware of this person's legislative work. So as an example, it could be thanking them for co-sponsoring the Medicare for All bill or for signing on to Representative Jayapal's letter against Medicare Advantage that was released earlier in the year. And the rest of the meeting attendees should then also take turns introducing themselves, like name, occupation, what region they're based in. Since we usually have limited time in these meetings, we try to keep introductions brief. Once everybody's introduced, then we'll go into the talking points. Each presenter will go through their issue, and then they'll end their portion with a specific and tangible ask. Ideally, each issue or talking point is reviewed 1 at a time to keep things organized and flowing. And then presenters should give space for the staff or member of Congress to respond with their thoughts and or questions. Meanwhile, somebody's keeping time and keeping everybody on track. And then again, for our lobbying day, we'll have room for 3 talking points. First is the equity report, second is WISER model, and then the third is a state-specific topic chosen by your local chapter. Once time is up, or if it feels like the conversation is coming to a natural close, the leader will typically end the meeting by giving a quick summary of what was covered and any next steps that the visit team needs to take, if applicable. And then the photographer can jump in and ask for a quick photo of the whole group, and hopefully they say yes. They don't always do, but it's nice when they say yes. And then you'll follow up if needed. And that's all for my portion. Hopefully this was helpful to some of you who might be less familiar with running legislative meetings. And like we said earlier, we'll be going into more detail in person in a week or so.
Fabulous, Angela. That was great. So hopefully you now have a blueprint for how this is going to work, and you should have gotten an email in the last day or 2 with the assignment of your group and who's going to be in there with you. And I would encourage you to reach out to the group and begin to think about this a little bit even before we get to DC. Now, last but not least, we're going to have Therese cover some of the overview and expectations. Remember, she is a medical student at Cooper Union. Therese, the floor is yours.
Thank you, Phil. So hi, everyone. I'm just here to give you a brief overview of what to expect for Advocacy Day. For the lobby meetings, everyone will be split into groups. Hopefully by now you'll have received your group assignments, but if not, you'll know them by the time of the conference workshop. And that's also when you'll meet your teammates in person and have a chance to practice together. Most groups will have 1 scheduled meeting with a legislator, though in 90% of cases, that will actually be with a staffer. Some teams might also decide to schedule another meeting or to drop in visits if everyone feels comfortable. So for example, if your group meets with the senator, or you can choose to stop by the representative's office afterward. In your meetings, we'd like you to focus on two key issues we just covered, the PNHP equity report and the WISER model. Lastly, we also want to make space for your own state-specific advocacy priorities as long as they align with PNHP's triple aim of better care for individuals, better health for populations, and lower per capita healthcare costs. If your team feels strongly about a particular issue, this is a great opportunity to bring it forward. Just be sure, though, that your group has talked it through and developed the message fully before including it. So that means clarifying what the issue is, why it matters, and what specific action you're asking legislators to take. And just like how we'll approach the other two main topics, it's helpful to prepare a few key talking points or a short story. Finally, make sure everyone in your group agrees on bringing it up so the message stays consistent and unified. For attire, plan to dress professionally and wear your white coat. And please leave off any additional buttons or pins on your white coat. Please also bring some photo identification. Ideally, that's a real ID driver's license, or if you're here on a visa, a photocopy of your documents at the minimum. Otherwise, we recommend you carry as little with you as possible. Security in the Capitol is strict, and anything not allowed in an airport is likely not allowed in the Capitol either. Now just a very quick rundown of the schedule. Again, we'll go into more detail later during the conference. At 7:30 a.m., the buses will leave from the Embassy Suites Hotel, and we know that's early, but don't worry, there will be coffee and snacks to get you going. You can leave your luggage on the bus, but just keep in mind that you won't be able to access it between 9 and 1:30. And at 9:30, we'll be kicking off the day with the rally. There will be a poster making workshop at the conference, so stay tuned for that. Between 10:30 and 1:30, legislative visits will take place. The buses will leave at 2 p.m. Some will go back to the hotel and others will go to the Union Station in DC, which connects directly to the airport by subway. All this information will also be attached to the email with the group assignments. And finally, just as a friendly reminder, I just wanted to mention that things might change as the day goes on, and that's totally okay. More importantly, we want you to enjoy the experience since this is a really exciting opportunity to make your voices heard. And with that, I'll pass it back to Phil.
Well, that was fantastic. So again, you guys have now seen a preview of everything that's going to happen, and a very active chat with a lot of ideas to share. I want to, before we dive into the question and answer period more formally, I want to drive home a specific point that I think some of you might be getting at, and try to emphasize how this is consistent with our mission. Because you're like, wait, we're Physicians for a National Health Program. Why are we sitting here talking about WISER? Why are we talking about Medicare Advantage reform? We view this as existential to the fight for single payer, right? Because the more that traditional Medicare gets perverted by things like the WISER model, or the more that Medicare Advantage gets its clutches in how Medicare is delivered, the harder it is going to be for us to make the case that Medicare for all is the solution that we want to fight for. So not only is this about protecting our patients, this is also strategic for us because, you know, if we're going to stand out here and say we want Medicare for all, and Medicare turns out to be a messed up, privatized, crappy program, honestly, that's actually not going to work for us, right? So we regard keeping Medicare as good as possible as an important part in getting us to Medicare for all. But I think you also have to remember that this is a power building exercise. So this allows us to build credibility with legislators. We can walk in there and say, look at this. This Medicare Advantage system is terrible. This WISER model sucks. You're now getting in front of legislators, being able to have conversations about healthcare. Now they know who you are. Now they know that PNHP is a trusted source of good information. When we get out there in a couple of years, or in 5 years to say, all right, it's time for single payer, they're going to say, oh, it's good to see you again. Yes, your data is good. You are right. And we totally believe in you. This is part of the power building that we do as an organization in building these relationships, and in setting ourselves up for success in the future, right? And so understand that, yeah, we're not out there with our guns a-blazing saying single payer now, but what we are doing is getting at the table. We are getting the opportunity to build these relationships. And honestly, if you have the chance to be like, hey, thank you for signing on to Jayapal and Dingle's single payer bill or Sanders' single payer bill, or would you consider signing on to it? There is no reason that you can't have that conversation. But we have to be clear and focused in our asks, because when you come out of a legislative meeting, you do have asks. You are going to ask them to do something, and you are going to want them to commit. And so those are the things that we're focusing on. But again, that doesn't mean you can't talk about the benefits, the importance of a single payer model. This is not the end, right? This is the beginning of PNHP becoming a big legislative lobbying force. So we're starting with some goals that we think are actually achievable. These are SMART goals, right? These are not necessarily the pie in the sky ones. That does not mean that we have forgotten who we are and what we seek. We view this as existential, as critical to achieving single payer. And with that, we're going to open it up for questions. And we've gotten a bunch of questions in the chat. I think a lot of them have been answered, but I'm also happy now if people want to use the raise hand function to try and field some of your questions as well, and I'll go with them in the order that we see them. And I see Les with his hand raised. Les, go ahead and unmute yourself and ask away. Oh, there you go. Unmute yourself first. Let me see if I can make that easier for you. Hang on. I can't unmute you directly, Les. There,
Okay, I got it.
Good.
This is fantastic. This would be a college level course. All of our teams should be out there doing that. I mean, this is incredible. And I noticed that everybody is still a student, and they've got all these skills. But I have one question. What studies have been done, as tight studies as we're proud of in PNHP, to show what type of lobbying works? Should we start out with the stories? Should we put all of our energy into the people that maybe are borderline and not singing to the choir? So that's one question. What works? And my simplistic approach is the stories tell it all. You have to show about how Mr. Jones thought he was saving money and he's able to buy his family a house and get out of the ghetto, and he's working for all the oligarchs and everything, except he's got a shitty plan, and his mother almost died of cancer. And just that would be a good thing to talk about. This is our point. Those lobbyists, we're up against people that are spinners like crazy. They're like J.D. Vance. He can turn an asshole into a mouth anytime he wants. So that's a little bit of a heavy thing, but just I am interested in what works. That's the simple question.
I think that's a great question, Les. I think that's probably part of what we're going to cover at the Advocacy Day training stuff that we do as well. I think that storytelling is a critical part of it. And I think as you prep for it, storytelling will be key. Do any of our other organizers on the call want to field Les's question? I'll open it up to you and not just take them all myself. Not hearing any of them speak up.
Maybe people that have been lobbyists.
Yeah, no. And so I think a lot of, that guide that we showed for the way the thing is going to break down, I think you can use that yourself. But I think that you're giving us some good food for thought to try and present to people, because of course we are doctors and we like evidence-based solutions to things. So what is the evidence for what people, what works most effectively? The next person that I see with a hand raised is Joseph. Joseph, go ahead.
Okay, thank you. Let me just say I thought this was one of the best meetings, well organized and to the point. But in discussing the Wiser model, one thing I noticed is I didn't see any criteria that looked at patient outcomes. I saw, saving money and stuff, and awarding for saving money. But is there any criteria that says, oh, did this produce better patient outcomes? And if it produced worse patient outcomes, should they not be given the award or the bonuses or whatever they are?
I think that that's a great question. I don't know the answer to it. Ed, I don't mean to put you on the spot. Is that something that you could address?
I don't think that's part of the design of Wiser to address that. I think they've just identified these things and these programs that they're going to intervene on, and their belief is that if they set up the right criteria, they can simply direct those procedures to the people who actually need them. And I've not seen, it's still early in the process, so they haven't released all of what they're planning to do with it. So perhaps they'll have some outcomes that they will report on, but that would be culturally inconsistent with them if they did. So I think you're probably spot on, Joe, is identifying one of the flaws with the program design.
Next question I see from Nancy.
Yeah, I'd like to address the farmer question. First of all, each of these presentations was great. It really addressed the current issues and bills we need to know about. But I don't think Bernie Sanders ever gets through a talk that he doesn't reference that every industrialized nation pays less and gets better medical outcomes. And I think that that needs to be in there in one way or another. It's the most convincing thing I find. And I think legislators are only interested in how much money it's going to cost. So we need to not lose that data.
Totally agree, Nancy. Belinda, I see your hand next.
Yes, I raised my hand because there was a question in the chat that we didn't get to, and I tried to scroll to see the name of who sent it, but I'm just going to address it. If this is your question, let me know if I did not answer it. Someone asked, also important to remember that 5-star plans get to enroll people year-round, so why aren't people of color able to access them preferentially? And I think the answer to this is that the 5-star plans may simply not be available in their geographical area. So it doesn't matter the time of year. People who are in areas where only lower quality plans are offered are trapped with only lower quality plan options.
Yeah, I think that's exactly right, Belinda. And I think that that also speaks to the flaws in the way that the entire system is designed, right? It cannot possibly be equitable if the only choices available to people of color are shitty choices, right? I mean, that's, you know, that we have a broken system, right? Which we all know. Les, I see you up with a hand up again.
No, that I didn't take it down. I'm just
Oh, you
listening.
didn't take it down. Okay, no problem. Other questions, other thoughts? I saw one in there about how do we introduce ourselves to staff in Congress. Thank you for meeting with us. We're here representing SNAP and the Physicians for a National Health Program and our partners to discuss how Medicare privatization is hurting patients in your district. I think that's a very reasonable opening. I know that there's a lot of chatter in the chat also about how you may not be with your state's member of Congress. And there's some reasons for that that are put up in the chat, and I'd encourage you to look at that. But I would also encourage you, when you are in your groups, to identify who are the people that are members of that state. I'm going to be going to meetings with people that are not from my state, and that's okay. But I also know that our congresspeople are going to listen extra carefully to their own constituents. And so please, in advance of you guys getting together and going in, make sure it's clear. And then in the meeting, say, I am one of your constituents, because they're going to especially be interested in what you have to say. And I wish we could get everybody in with all of your respective states. Like I said in the chat, I'm actually going to reach out to see if me and Dr. Campbell can go see our Hawaii congresspeople, because we've met with all of them before. I've got the names of all their legislative aides and their contact, and we're going to be on the Hill. We might as well pop in and say hello, right? And see if we can score some time with them. I see Dan's got his hand up. Dan.
Thanks. My question is about those of us who are going to be speaking to pretty loyal MAGA supporters right down the line. Our team Team 6 from West Virginia will be meeting with Senator Capito's staffer, and we may try to go see Carol Miller, one of our 2 members of Congress. And so I'm curious about other people that are in our situation, how you're approaching that. Until tonight, I've been thinking about mainly we're going to speak truth to power. But what I heard tonight was really helpful, especially what Angela said about how to conduct ourselves in the interaction. And also, I thought that the presentation on Wiser gave me some talking points that I didn't have, because the staffers are very well informed and smart about health policy. They're just captive of a incredibly bad employment situation. But presenting the data about the inequity, I'm sorry, not Wiser, the inequity study, presenting the data, actually both. So I came away with some really good asks for our hopeless members of Congress. I'm curious if other people are in our situation, you're sort of stuck going to speak to MAGA supporters, who aren't going to change anything until their boss does.
I think that's such an important question, Dan. I'm not sure I know. I have my thoughts about the answer, but I also want to see, have any of the rest of you thought about how you might strategically address this? I mean, to me, I think you have to, what are the things that they're focusing on? They're focusing on waste, fraud, and abuse and wasteful spending, right? I think if that's a strategy that speaks to them, certainly you can use our Medicare Advantage, all of the stuff that we present on Medicare Advantage, to actually demonstrate how fraudulent it is, abuse, how it actually abuses people of color in this country, right? 3, how wasteful it is because the outcomes are worse. So in a way, you could frame everything that we see in these kinds of programs as waste, fraud, and abuse. That's the language that they want to speak. Are they going to hear that? I don't know. But I think it does mean at some level trying to meet them where they're at. But I don't know if folks have other thoughts about that. And if you do, maybe your hands are up and I'll react to you. Oh, Ed, you came off mute. Let me see. What do you have to say?
Oh, you're watching too closely, Dr. Verhoff.
I am, buddy.
Yeah. So yeah, I think Phil's got it exactly right, Dan. You want to stay in, and you know this because you've done more of this than a lot of folks done. But you want to stay in their language. You want to be speaking their terms, and it's the things Phil said. It's accountability. We don't have accountability from Medicare Advantage. It's transparency, and we don't have that. A lot of the stuff that we are asking for, we don't have access to. That's sort of the point of some of the bills from Representative Pocan. So the key is to stay in their tone and address the issues that they would be concerned about. Like Phil said, all the waste, fraud, and abuse, pretty much everything that we've been saying fits into that.
I see in order of hands a number more. I'm going to go with Dixon first, our esteemed master of communication at PNHP.
All right, thank you. I just wanted to amplify something that I know has been mentioned a few times, and that is the importance of bringing personal stories into these meetings. I think we're going to be talking about some complicated issues. When we're presenting the equity implications of Medicare Advantage and when we're talking about Wiser, and we have some great leave behinds that go into all of the details that staffers or members of Congress would need to know. But everybody who is going to be participating in these meetings, everybody on this call has a really vivid personal story or an experience with a patient that you can share, that's going to be probably the most compelling thing that they hear in those meetings. So I just encourage everybody to start thinking about those now. What are stories that you've encountered in your practice or in your life or with your friends and family that really, bring these issues to light and illustrate them in a powerful way and bring those into the meeting.
Thanks, Dixon. Thanks for that reminder. It's so true. Phil Lichtenstein.
Thanks. I think that there's an obvious 2x4 that you can take and just whack these guys upside the head with that really illustrates brilliantly waste, fraud, and abuse. Medicare Advantage is an experiment that's been going on for 25 years, which promised at the very beginning that they could provide care less expensively and at the same time produce better outcomes. And we know that over the span of those 25 years, the results in both categories have gotten progressively worse, with Medicare Advantage falling farther and farther away from what they promised. Last year, and you all know this, it cost 18 to 20% more per patient per year, to provide coverage for patients in Medicare Advantage. 20% more, which works out to close to $90 billion of wasted investment in healthcare outcomes. That's the crux of the issue. What they ought to be looking at is what can you do with Medicare Advantage, to produce outcomes that were, that come within 1 to 2% of costing what traditional Medicare does. And it, I find that when I have that discussion with, various reps, that it sort of gobsmacks them.
Yeah, such a great point, right? That traditional Medicare is so much more efficient, right? Such a better bang for your buck on return for investment. Thanks, Phil. Steve Auerbach.
Hi, thank you. Most of what I want to say is really to second what other people have said, in terms of, speaking to a Republican congressperson. Quite frankly, I don't know that racial inequality is something that's going to move them. They are officially against it. It's a major plank of their platform. I mean, the whole DEI stuff. I mean, I think we need to have messaging that focuses on poor everybody and rural, for those Republican members. I've dropped some stuff in there about hospital closures. It's sort of in the sad but true. It's sort of an extreme version of what PNHP has always had in terms of talking to conservatives. The wastewater abuse is by Aetna. The waste, fraud, and abuse is by United. They are the sources of the waste, fraud, and abuse. And I also would second the messaging around the, nothing that we're actually proposing. Everybody views us as radical lefties, right? But nothing that we're proposing is actually, on an international basis, radical or extreme at all, right? Everything we're talking about is normal in every other rich capitalist democracy around the world. And it's the United States' current system that is the extremist outlier. I don't know how you get that to a quicker message, but something like that. So yeah, just seconding what some of the other folks said. And also just for those that really want the deep dive wonk, PNHP's prior to reports, the PDFs I've dropped into chat, are worth reading in full. They include stories that one can use for any audience. And so the prior to Medicare disadvantage reports, I would highly recommend folks reviewing in full as well as the new one.
If I could,
I think one of the points. Oh, go ahead. Yeah, go ahead, Ed.
Yeah, if I could just hop in on how to use the equity report for people who hate DEI. You're right. The folks in Congress who want to ban DEI initiatives aren't going to care about our evidence that Medicare Advantage hurts people of color. But what our goal for the report mainly is to reach those folks in the middle who believe the lies from the insurance industry. And so our goal with them, and even for the people on the far right, is to at least undercut. The industry has shifted from talking about any other issue to talking about equity as the reason that Congress should leave them alone. they present this false information suggesting that they produce better health outcomes. So I think when we're talking to the most conservatives, we should be probably emphasizing the piece of how upcoding confounds the literature. Let them really understand how upcoding isn't just tens of billions of dollars of overpayments, but it also confounds the literature. And if they look at any of the literature that AHIP presents to them, they'll find that it's not corrected for upcoding, or if it is, it's only the most ineffective correction for it. So we just want to disarm the tools that the insurance industry is using to fight us. That's the goal, is just to at least take away the weapons that the insurance industry has.
I think also, I think it's important that some of you will be going into blue offices and they will be perfectly happy to hear about equity, right? And so, this is a little bit about knowing your audience and trying to tailor that message to them. I think that we can't tell you that everybody's going to go in with the same script. I think you have to know a little bit about your audience before going in, which is why we are preparing you like all of this. Joseph, I see you've got the next hand. Oh, Joseph, unmute yourself.
I want to address two comments. The first thing is by Dan Doyle, who was speaking about that these programs haven't worked. MedPAC, with their recent reports, said that programs that are essentially Medicare Advantage, I've forgotten the technical name, have never saved money for over 40 years. So why do we keep trying these programs? I just want to emphasize that point. The other point I want to make relates to Dixon's personal stories. Now, unlike many of the people here, I am not a medical professional, but when we talk about stories, we tend to emphasize the stories about problems. But for example, I'm on traditional Medicare and it was much better than the private insurance that I'm on. I can get the doctors that I need. So I think when talking about personal stories, if you can have people who talk about their positive experiences with traditional Medicare, or if you can relate stories from patients about positive experiences with traditional Medicare, I think that would be helpful. Give this senators and reps some positive examples.
Love that, Joseph. Love it. Linda, I got your hand next.
Yeah, I just want to note that PBMs, pharmacy benefit managers, even though they are not technically the payers, they are the payers' contractors. And every conservative, or there are a lot of conservative states, I would note Ohio, Kentucky, West Virginia, have been taking actions against PBMs. And so if you want to start with that notion that even in our conservative state, we're going after the fraud, waste, and abuse being caused by PBMs. I think Ohio started it. They're a Republican-led state. They saved hundreds of millions of dollars in their Medicaid program by going after them.
Love it. And a nice way to tie in some of the other work that we're doing and talking about deprivatizing Medicaid too. Check that report out. That sucker is a tour de force. Robin, I see your hand up next.
So we were brought up before that a lot of the more conservative legislatures won't really care about equity. But one thing I realized is if there's a program that gives a big disadvantage to people in poor areas, it's not only people of color who are usually affected, but also typically rural communities. And a lot of the extremely conservative politicians do represent rural communities. So with them, you might emphasize that a lot of the, I don't know the numbers, but I would imagine that a lot of the better plans are not available in rural areas either. So that might be something to check into and emphasize.
Absolutely. And we know that certainly in rural districts, the narrow networks used by Medicare Advantage and frankly used by commercial insurance further disadvantages folks in those rural areas. And so again, I think that can be a very important talking point depending on your legislator and what their district covers. I know one of ours in Hawaii is very big on rural healthcare because much of Hawaii is actually rural. So I think that these are really great thoughts that I hope you all are incorporating as we go through this discussion. Any other thoughts? I like Kathy's point. It can be helpful to get the legislator or staffer to talk about health issues in their own lives. I think if you can engage somebody in a personal conversation, that may also be just that more effective, like that comments as well. Yeah, Republicans are pushing back on prior auth. Oh, go ahead, Ed.
Yeah, one thing to add into Robin, there's actually a section in the equity report specifically addressing how these dynamics are affecting rural hospitals and driving up rural hospital closures. So if you're planning on having that conversation, you should probably read that section closely. There's a lot of information in there about it.
Love it. Okay, I don't see more questions, but I'm wondering, how do we avoid staffers eating up our time? Angela, do you want to take that one? But unmute yourself if you do. Yeah, there you go.
Yeah. This is something that's hard. A lot of staffers like to maybe respond with something a little more inflammatory. And I would say the best way to avoid a staffer eating up your time is to be prepared and to make sure that whatever you prepare is very specific, and is not convoluted anyway, so that you can always circle back to that one simple ask that you have. So if the staffer, let's say, goes on a rant about like democratic socialism or something, and then it's like, okay, that was great. Now back to, like this amendment on the Wiser model. Like, is this something that this member of Congress has thought about? If so, what are their thoughts? Would they be willing to take X, Y, and Z? So for a lot of us, we have had, like, organizing in Tennessee is definitely not a very welcoming environment. But I think always trying to find common ground, appealing to, their language, rural healthcare, farmers, rural medicine is very important. And then trying to keep things very simple and tangible for the staffer to be able to come back to is important.
Love that answer. Ed.
Yeah, I think you're exactly right with the answer. A couple of things to amplify. First, we always want to be polite to them, so we don't want to just cut them off. We want to be polite. We want to build that relationship. But they will, if they don't want to talk to you, they will jump into either the three things I found they do. They'll talk about some social topic, sports, fishing, I don't know what, and you'll think, well, golly, I'm making friends with this person. Let's have that conversation. Or they'll talk about something inflammatory. Gee, that's interesting, but don't you know most of the money is being spent at the end of life? Let's talk about what we can do about end of life wasting money. And you'll think, yeah, boy, you really get it. That's great. Or the third thing that they'll do is they'll say, let's take a photo. And yeah, a photo at the end is great, but I've seen them bring in, say, oh, there's my photographer. Let's go get a photo. And then you consume 10 minutes because, oh, that didn't come out right. Oh, it did. And then your 15 minutes is gone on these things. So it's important to be polite. If they ask for the photo early, you want to say, I'd love a photo, but can we, you're going to disappear so quickly. Can we come back to that? Because I really want to make sure we talk. So be polite. I love that. If they want to talk about sports or something, go, man, that'd be great, but can we do this stuff first, but try to, exactly like you said, try to get back onto your topic as politely as you can early on. And the trick to that is knowing that that's what they're doing, knowing that they're not just being polite and social, they're frigging busy too. They're intentionally wasting your time when they bring up that kind of stuff. They know that they're bringing up something that's either off topic or is unactionable. So you want to get them back to the stuff that is actionable without saying, "Oh, shut up about that. I don't care about." You want to be empathetic, agree, say, "Yes, that's an important thing. Let's talk about that." If there's time left after we talk about the reasons that we're here.
Awesome. Yeah, get a beer later. So with that, it's the top of our hour. And I just want to thank everybody, especially our fantastic panel of Angela, and Daniel, and Teres, and Kyle, and Belinda, and really Ed for some of the behind the scenes work, and our staffers who've just been absolutely out there killing it, trying to make this happen. Mandy and Di and Ananya and Lori, and everybody is absolutely putting in a ton of work into this. And we are so excited to share this with you all when we get together in just a week or a week and a half. Fortunately, I hope we can all make it there with all of the crazy government shutdown things that are happening, and I'm really looking forward to sharing this experience with you all. So thank you all so much. Feel free to email us with more questions as you think of them, and we'll continue to try and take them into account as we prep for Sunday. So thank you guys all so much, and have a great rest of your day.